Hi, everybody. Thank you so much for joining me today. Let's give it another minute or two to see if anybody else comes on, and then we'll get started. Okay. Hi, everybody. My name is SD Rose, and I am a genetic counselor with JScreen. Thank you all for coming today. For those of you who have friends or family members who are unable to make the webinar, this is being recorded, and we are going to post it on our YouTube channel. So you are welcome to refer anybody you know to the webinar. So at JScreen, we decided that we would speak about cancer genetic testing for males in honor of Men's Health Awareness Month. So the theme of today's speech is going to be about cancer genetic testing specifically and in males. If anybody has any questions, you can feel free to write them in the Q&A box, and hopefully we'll have time at the end to address them. So let me just move forward if I can't. Okay, so the learning objectives of today's webinar is to first understand what hereditary cancer is. Then we're going to talk about how genetic testing is important for the treatment of cancer and also for the screening and prevention of cancer. And then we'll also discuss how genetic results can impact a family. So let's get started with what is hereditary cancer. So it's important to know that not all cancers are genetic. Actually, most cancers are not genetic. Most of them are sporadic, or they happen by chance. As we get older, our cells tend to mutate a little bit, and that's what can cause cancer. We are exposed to environmental toxins and just to aging, and that's why most people end up getting cancer. It has nothing to do with their genes. However, a small percentage of cancers are due to changes in genes that can be passed down from generation to generation. And when that type of cancer happens, when it's due to a change in a gene, you can see that other people in the family could also be impacted by that type of cancer or other types of cancer that are associated with that gene. So I'm going to explain to you what these cancer genes are, and then we'll talk about how they can impact the family. So here is a picture about how cancer genes work. Now, we actually have many, many different cancer genes. We probably have well over 100 of them. And what these cancer genes have in common is that they all have the same function or the same job in our body. And that job is to protect us from getting cancer. So when a cancer cell tries to enter the body, these genes kind of put up a shield and they say, no, you're not allowed in the body, and they push the cancer cells out. So cancer genes are very good because they're protecting us from getting cancer. However, sometimes a mutation occurs in one of these genes. A mutation is another way of saying a change in the structure of the gene. So when there is a mutation or a change in the structure of the gene, that can cause the gene to not work 100%. So again, when the cancer genes are working, they're protecting us from getting cancer. But when there's a change in the gene, that can make the gene not work so well, thereby allowing cancer to enter the body. When somebody has a mutation in a cancer gene, therefore, they are more likely than others to develop cancer at some point in their lives. Now, depending on which cancer gene we're talking about, there are many different risks associated with it. So there are some genes that have to do with colon cancer, some genes that have to do with breast cancer, some genes that have to do with melanoma. And every single gene is kind of unique, and the conversations that we have with our patients who are positive for a genetic mutation is very personalized and unique to that patient and to the gene that they test positive for. So here I'm going to give you an example. Oh, here's just a picture of the risk. Somebody who doesn't have a mutation in a cancer gene also has a risk for cancer because everybody has a risk for cancer. As I mentioned earlier, most cancers are not genetic. They happen sporadically. So everybody on the planet has a risk for cancer. But if they have a mutation in one of their cancer genes, their risks are going to be higher. So here I wrote out an example of one of the genes that we frequently talk about at JScreen. I'm sure many of you have heard of the BRCA1 or the BRCA1 gene. Now remember, anybody could get cancer. And those risks are written here in the gray bars. So every female has about a 13% chance of getting breast cancer, a 2% chance of getting ovarian cancer. Every male has a 12% chance of prostate cancer. Males and females have about a 2% chance of getting pancreatic cancer. And males have a very low, less than 1% chance of getting breast cancer. However, if there's a mutation in their BRCA1 or their BRCA1 gene, those risks are higher because the mutation makes the gene not work properly and causes an increased risk for certain cancers. So for example, if a female is positive for a BRCA1 mutation, her risk for breast cancer goes from 13% to up to 87%. Her risk for ovarian cancer goes from 2% to about 60%. A male's risk for prostate cancer is also increased. Males and females have a slightly increased risk for pancreatic cancer, and males have an increased risk for breast cancer. So here you can see that if somebody has a mutation in the BRCA1 gene, they are at increased risk for certain cancers. It's not 100%. None of these bars show 100%, but the risks are pretty significant compared to people who don't have a mutation. But remember that the BRCA1 gene is only one example of a cancer gene. It's not just BRCA. There are many other genes that are associated with breast cancer. And it's not just breast cancer. We have genes that are associated with many different types of cancer. So on our JScreen test for cancer, we're testing breast cancer genes, we're testing ovarian cancer genes, we're testing uterine cancer genes. We're also testing for genes that are only associated with male cancer risks, such as prostate and testicular cancer. And then we're also testing for many other genes that are associated with cancers that can affect males and females. So as you can see, genetic testing is not only applicable for females, it's also applicable for males. Now, what do we do when it turns out that somebody has a mutation in one of these genes? So knowing that somebody is positive is very, very important, whether they're male or female, because it can inform medical management. It can help people decide what to do and what kind of a medical plan to make for themselves. And it can also help us figure out who else in the family is at risk and might want to consider getting tested as well. So here I have written out what we do for people who are male and test positive for a mutation in a cancer gene, but don't currently have a diagnosis of cancer. So depending on which gene it is, as I said earlier, it's always a different conversation. But here I wrote out a couple of examples of different cancers that we can find people are at risk for when they test positive for a cancer gene. So for example, let's say if a male tests positive for a BRCA1 mutation, as we discussed before, which increases the risk for prostate cancer. If a male knows that they have this mutation and they have this increased risk, it is recommended that they do extra screening for prostate cancer. So for example, they might start doing a blood test called a PSA test, which can look for markers for prostate cancer in their blood. If they're positive for BRCA1, they might also do a clinical breast exam. Most males don't have clinical breast exams every year at their doctor, but if they know that they have a mutation and they know that they're at increased risk for breast cancer, then they might consider doing a doctor exam, and also they should be doing exams by themselves at home. They should be doing self-exams between their doctor's exams. If somebody knows that they're positive for a melanoma gene and they have an increased risk for melanoma, it's recommended that they periodically go to the dermatologist who can do a full skin exam. If somebody knows that they're positive for a colon cancer gene, they might do earlier and more frequent colonoscopies than the general population might do. So all of these are examples of extra screening that a male might do if he learns that he's positive for a mutation in a cancer gene. Sometimes they're also given options to reduce the chance of that cancer happening in the first place, not just to screen for it and look for it at an early stage, but to prevent it from happening in the first place. So for example, there is a gene called the CDH1 gene. If somebody has a mutation, male or female, in this gene, they are at increased risk for a very, very severe type of stomach cancer. And it's recommended that if they're positive, they consider doing a surgery, a preventative surgery, to remove their stomach. Having this surgery reduces the chance of getting that type of cancer of that type of stomach cancer by a very, very large percentage. So as you can see, when somebody's positive, they might have options for cancer risk reduction, and they'll definitely have options for cancer screening and being a little bit more on top of things so that if the cancer is going to happen, they're going to catch it at an early and more treatable stage. When a female is positive for a cancer mutation, we also have similar conversations with her about what they can do to screen for cancer and find it early if it's going to happen. And in some cases, they also have options to reduce the risk of those cancers happening by undergoing preventative surgery. So for example, if a woman tests positive for the BRCA1 gene or any other breast cancer gene, she might decide to do more frequent and early imaging like mammograms and breast MRIs, or she might decide to do a risk-reducing mastectomy, which is a surgery that removes the breast tissue and also reduces the risk of getting breast cancer in the future. Similarly, for a woman who tests positive for an ovarian cancer gene, it is recommended that she do a surgery called a risk-reducing oophorectomy, which also lowers the chances of getting ovarian cancer. Same with the men, they're also recommended to do early and frequent colonoscopies and skin exams if they happen to test positive for a melanoma or a colon cancer gene. Now, when somebody already has a cancer diagnosis, sometimes their doctors want them to do genetic testing anyway. So the genetic testing is not necessarily to see if they're at risk for cancer. We know they are because they already have a diagnosis of cancer. But if they know that they're positive for a genetic mutation, sometimes that can help in terms of their treatment and deciding what course to take in terms of surgery and medication. So for example, let's say a woman has a breast cancer diagnosis and she's considering having a lumpectomy for the mass in her breast tissue. Or she might be considering doing a unilateral mastectomy where she removes that whole entire breast that is affected. However, if she decides to do genetic testing and it turns out that she's positive for a mutation in the BRCA1 or the BRCA2 or any of the other breast cancer genes, then she might decide to move forward with a more aggressive type of surgery, such as a bilateral mastectomy, where they remove both breasts, because that can reduce the chances of getting cancer again, which is much more common in people who have a breast cancer mutation. Similarly, for men and women who test positive for a gene that causes Lynch syndrome, which is a colon cancer syndrome, if they know they just have colon cancer not due to a genetic change, they might decide to do a partial colectomy where they only remove part of the colon that's affected by the cancer. But if they learn that they're positive for a genetic mutation and they have an increased risk for further cancer in the future, they might decide to do a full colectomy where they remove the entire colon. So as you can see in both of these examples, knowing that somebody is positive for a mutation can help the doctors decide which surgery makes the most sense for that patient. Also, sometimes, not always, but sometimes there are medications that tend to work better or are more effective in people who have a specific mutation. So for example, for people who have a BRCA mutation or BRCA mutation, there is a certain medication called a PARP inhibitor that preferentially kills cancer cells in those people. So we know that when somebody's positive, PARP inhibitors are a very, very effective medication against breast cancer. When somebody has a mutation, they don't only need to think about themselves and their own medical management, but they also have to think about how these genetic mutations can affect other people in their family. Most cancer gene mutations work in a way that's called autosomal dominant, which means that when they have a mutation, each of their children has a 50% chance of inheriting that mutation from them. It's totally random. They don't get to decide. It's 50-50. And in addition to that, it doesn't make a difference if it's a son or daughter. So anytime somebody has a mutation, there's a 50% chance for each of their kids to have it. If somebody has that 50% chance and happens to not get the mutation from their parent, then it stops there and they don't need to worry about their children. So there's no such thing as like skipping a generation when it comes to cancer gene mutations. If somebody has it and their child doesn't get it from them, then that child and their future children don't need to worry about it, unless of course their other parent might be a carrier, which happens very rarely. So as you can see, even males who test positive for mutations in genes that generally only affect females should still, be careful about knowing this information, because if they have daughters, it could be really important for their daughters to know. So even though those genes like the BRCA1 and the BRCA2 gene generally affect females more significantly than males, it would be important for a male to know whether or not he's positive so that he can let his daughters know about their results. It's also very helpful to know whether or not somebody's positive when they're planning to have their families because of the way that this is inherited. So again, when somebody's positive, each of their kids has a pretty significant chance of testing positive as well. Many people do take on that risk and don't do anything about it. But as part of genetic counseling, we also give people different options in order to get ahead of that risk if they're still in that part of their life. So you can't do much for family planning if you already have your children, but for our younger patients who are considering adding to their family, we do give them different options when they test positive. So for example, some people who test positive and are planning on having children and want to do anything they can to ensure that they're not passing on their mutation, they have different options using assisted reproductive technologies. So for example, one option within that assisted reproductive technology realm is to undergo in vitro fertilization. You might have heard of in vitro fertilization or IVF before. Usually people recognize it in the realm of infertility. So couples who are having trouble getting pregnant might undergo IVF in order to get pregnant. Basically, what an IVF procedure or process is that the female gives an egg sample, the male gives a sperm sample, and they combine it in the lab, and they create an embryo in the lab. They let that embryo grow for a few days, and then they implant it into the woman's uterus, and hopefully she gets pregnant. What I'm suggesting here is that when somebody knows that they have a mutation, whether it's the mother or the father, and they want to ensure that they're not passing along the mutation to their child, they undergo the exact same IVF process that an infertile couple might undergo, but they add in one step along the way, and that step is called pre-implantation genetic testing. What that step is that once the embryo is created and sitting in the lab for a few days growing, they can actually take out one or two of the cells of that embryo, and they can do genetic testing on that cell. And that will tell us whether or not this embryo has inherited the mutation, 50-50. If it's an embryo that has not inherited the mutation, great. They'll take that embryo, they'll implant it into the woman's uterus, and hopefully it will take and she'll get pregnant, and it will be with a child that will not have the mutation. If they see that the embryo has been affected, if it does have the genetic mutation, they'll discard it in the lab and it will never turn into a fetus. It will never become a baby. So it's basically a way of avoiding getting pregnant at all with a child who's going to have to deal with those cancer risks in the future. Other couples might use different types of assisted reproductive technology, such as gamete donation, where the mother or the father is not the biological father because they get either an egg donor or a sperm donor, who obviously has been tested and is not a carrier of a mutation. In some cases, people will decide to get pregnant naturally, and they can test a baby during a pregnancy to see whether or not it has inherited that mutation. And other couples might decide to adopt, to foster, or to not have biological or any children at all. So as you can see, when somebody is still in their reproductive years, it could be very helpful to know their status when it comes to cancer genes, because if it turns out that they're positive, they'll have all of these options if they're interested. The JScreen process is very, very simple. We are testing for over 70 different cancer genes as of today. When somebody is ready to get tested, they go on our website, jscreen.org, and they request a JScreen cancer gen test. We will ask you for some demographic information. We'll also ask you for your doctor's information so that we can facilitate a doctor's order. After that, we send you your spit kit, you spit into the tube, send it off to the lab, and then the results come back about 3 weeks later, and they come straight back to us at JScreen. We let you know that the results are ready, and we will schedule a genetic counseling session either by phone or by Zoom with everybody. So it doesn't make a difference where in the country you are. As long as you're in the US, we will provide genetic counseling by telehealth. In cases where somebody's positive, where there's more follow-up that's needed, we will also get in touch with the doctor who ordered your test just to make sure that they know next steps and they can make a plan with you in terms of, following up with certain specialists. And also in some situations, we'll send people to appropriate resources that can help them. So for example, one of our partner organizations is Charlotte, which some of you might have heard of. They provide psychosocial support for men and women who are impacted by hereditary cancer mutations. So that's just an example of one of our partner organizations for people who test positive for breast cancer mutations and other similar mutations, but we also have partnerships with many other organizations. So as you can see, the JScreen process is very simple, it's very easy and convenient, and everything is done very privately, and it's all done through our certified genetic counselors who are part of Emory University and their Department of Human Genetics. So everything is done in a very medically appropriate way, and everything is also very HIPAA compliant and very private. I'd like to end off by saying that knowledge is power. I know that it is very cliche, and you've probably heard this a million times, but as you can see, knowing one's status when it comes to cancer genes could be very helpful for their own health and also for other people in their family. So if you or anyone you know might be interested in getting tested, male or female, it doesn't make a difference. This can be really, really helpful information for them and for their loved ones. And that is the end of my presentation. If anybody has any questions, you can feel free to put them in the question box and I will try to answer them. So I see that somebody already asked a question. The question is, what is the status of the research as to why men or women with BRCA1 mutations don't get breast cancer? I think that's a really good question. So basically the question is, how come some people get breast cancer and some people don't get breast cancer with the mutation? How come some people get ovarian cancer, but their brother might get pancreatic cancer? Why is it that having a mutation is not exactly, or doesn't present exactly the same for everybody? And the answer is that I don't know the answer. There is a lot of research going on to try to figure out whether there are other factors or other things that might interact with a BRCA1 mutation that could make it act a certain way. So maybe there are other genes that interact with the BRCA1 mutation that make some people have breast cancer and some people have ovarian cancer. So there has to be some kind of other external factor. It's not just the BRCA1 mutation, but we're not quite there yet in figuring out what those external factors are. Hopefully we'll get there soon. Okay, somebody else asked, for a man age 53 who has a BRCA1 mutation, what annual tests should a primary care do going forward that is different to a man who does not have a mutation? So as I mentioned earlier, it is recommended that men who are positive for a BRCA1 mutation have that PSA blood test, which is a prostate cancer screening test, every year. In addition to that, they should be doing periodic chest wall exams. Basically, they should ask their doctor how to feel around for a breast cancer lump. And in addition to that, between their annual visits, they should be doing that between their annual visits. And in addition to that, every year when they go to the doctor, they should be asking the doctor to do a clinical exam on them as well. Most men do not have imaging such as mammograms. It's not really that common, but at least, they should have a doctor take a look, and also they should check themselves between those doctor's visits. When it comes to the pancreatic cancer risk, unfortunately, there is no good pancreatic cancer screening at this time. Right now, the recommendations are only for people who have a very strong family history of pancreatic cancer and a BRCA1 mutation. So if there is no family history right now, there are no recommendations for pancreatic screening. But if there is a family history, it is recommended that people consider doing an upper endoscopy, an endoscopic ultrasound and or an MRI of the pancreas. There are many studies going on around the country to try to figure out whether these are good or effective screening tools for pancreatic cancer, but we're not quite there yet in terms of recommending it for everybody. So for all of my male and female patients who are positive, I do recommend that they seek a trial in their area to see whether or not they can get on some kind of a protocol where they do pancreatic cancer screening. Okay, I have another question. So this person said, my grandfather died of leukemia in his early 60s. I am 47. Is there a genetic test for leukemia? Also, did the general JScreen test for possible conditions for children that did not include cancer tests? Correct. Okay, so two different questions here. So leukemia is generally not understood to be genetic, or not hereditary, I should say, not something that's passed down from generation to generation. We definitely do include some genes on our cancer gen panel that are associated with leukemia, but there are a lot of other factors that are not genetic that have to do with the onset of leukemia. So yes, we test for some leukemia genes, but most cancers of leukemia are not genetic at all. JScreen, in addition to doing our cancer gen test, also has a completely separate test called our ReproGen test, which screens young individuals for conditions that can affect their babies. So for example, Tay-Sachs disease, a very common Ashkenazi Jewish condition. When somebody has a mutation for Tay-Sachs, they don't have Tay-Sachs, but if their partner is also a carrier, their kids could potentially be at risk. So our cancer gen test and our ReproGen test are very different. The cancer gen test looks for personal health. It looks to see if the patient themselves might have these cancers. And the ReproGen test is only for reproductive family planning when people are concerned that they might pass down something to their children. So they're completely different tests. You can go on our website and you can request whichever one or both you're interested in. Another question, so many questions. Okay. The next person asked, is there a relationship between melanoma and prostate cancer? There might be. Yeah, there certainly might be. There are some genes that are associated with both. And that's why doing a very comprehensive test where we're looking at many different genes, such as our cancer gen panel, could be really helpful for people who have a personal history or a family history of any of these cancers. By the way, just something I wanted to mention is that not everybody who comes through JScreen has a family history or a personal history of cancer. Some people want to get tested because they don't have a family history, but they also don't know so much about their family. So they are concerned. Some people just want to know their risks, and even if they don't have a family history, are aware that being of a certain ethnic background can increase one's chance to have a certain result. So for example, people who are Eastern European Jewish or Ashkenazi Jewish have a 10 times greater risk than other people to have a BRCA1 or a BRCA2 mutation. So many people who are of that descent, who are Ashkenazi Jewish, don't even have a family history, but they're interested in getting tested just because they have a higher than normal chance to be a carrier. 1 in 40 Ashkenazis is a carrier. So it's really important that anybody with a family history or even without a family history considers getting tested as long as they're ready to have this information. Some people are not interested in knowing and would rather leave things to chance. But if somebody might use this information to help them, doing a very thorough test, a very comprehensive test that includes many, many genes is very helpful. Okay, another question. If somebody was diagnosed with colon cancer in their 30s and underwent genetic testing several years ago with a mutation that came back as the possible cause of cancer, is there a way to get more information on whether the mutation was the cause? Is there a certain age when their children should get tested? So, the genetics world is a very, very fast-paced world, and genetic testing and genetic information from years ago is often very, very outdated. Only a few years ago could make a really big difference. So when somebody was tested several years ago, as this person had asked, I would recommend that they reach back out to the person who ordered their test, their genetic counselor or their doctor, to ask if any new information has been found since they were last tested. So that's one way to keep up with the knowledge. There are also some studies that are going on where people can add themselves to registries to get informed when there are updates to the information. And I'm happy to share that information if anybody would like to know to be part of these registries. So in other words, when somebody has had testing years and years ago, it's often outdated and there's new information that's available. Even for people who get tested years ago and test negative, it might be worthwhile to consider getting retested with a more comprehensive test. This person also asked, is there a certain age when children should get tested? It is generally not recommended that young children get tested or teenagers. And it's recommended that people only get tested starting in their mid or so 20s. There are certainly some exceptions to that rule, such as when a cancer gene is associated with a childhood cancer. And in those cases, we will test children. But normally, or typically speaking, we only test people usually, after their teenage years. But again, there are always exceptions, and we're happy to talk to people who might be interested in testing earlier. I think that's it for the questions. If anyone else has any questions, they are welcome to put it in the chat, or they're welcome to find me privately and ask me any questions. I will give you my information for anybody who would like to meet me or speak with me privately. My email address is esther.rose@emory.edu, ESTHER.rose, ROSE, @emory.edu, esther.rose@emory.edu. I'd like to thank you all for coming today and for taking the time out of your busy schedules to learn a little bit. I think it's great. And if anybody would like to get in touch, I'd love to meet you. Thank you.